My name is MRCOG. I'm a member of the Royal College of Obstetricians and Gynaecologists, and I work in the NHS. I've been guiding the MRCOG Part 3 candidates for the last few years. And through the forum of this channel, Grasp MRCOG, I make free videos to make things simple for the candidates, and that can also be beneficial for all of us from the point of view of our day-to-day practice. If you want me to make videos on any topic that you think is important from the exam point of view or otherwise, just send me a message. So let's talk about the antenatal care module in MRCOG exam today. Antenatal care in the UK is provided mainly by the midwives and the GPs to all the women. However, some women who are high risk, they are referred to the obstetric team as well. So you will be only seeing the women who are high risk or who have got some issues with their pregnancy or who want to discuss something with you with regards to labor and delivery. So let's discuss a few cases. Women can be referred to the obstetric team because of risk factors in the previous pregnancies related to their obstetric history. For example, previous cesarean section, previous one cesarean section, she wants to give birth in a midwifery-led unit, or she wants to give birth in a pool. Women with previous 2 cesarean sections, she wants to have a vaginal delivery. Women with twin pregnancy who wants to deliver at home. Women with raised BMI. Women with the history of PPH. Women with a history of third-degree perineal tear. So these are just a few examples. There could be fetal reasons for referral as well, such as fetal abnormalities. Some abnormalities could be compatible with life, and some abnormalities that could be incompatible with life. Based on these two, the management will definitely be different. Antenatal care is all about risk assessment. So whenever a woman comes to you in the clinic, in addition to the things that you are already referred for, you also have to see what other risk factors are there in her history. Whenever you look at any scenario, do not just focus on the things that are mentioned there and that are highlighted. Also look at other risk factors around. For example, a woman who has got a medical disorder, which is like very well controlled and a minor problem, which doesn't have any impact on her normal life. She's not on any medication, but she's got a raised BMI. So do not forget about the BMI. It's important to have a full assessment. It's important to have a wider vision, and it's important to have a holistic approach. Okay, so it's important not to focus on the things that you are given information about. So that is why an important part of this management of the antenatal care is to take a very good history. So let's see how you can take the scenarios in exam setting. So you will introduce yourself to the patient. Hello, my name is Amara. I'm one of the doctors in the clinic today. May I please confirm your full name and date of birth, or full name and age? And after that, again, you can either ask an open question, how may I help you today? Or you can tell her the information that you are already aware of, or the information which is given in the letter by the GP or by the midwife. For example, I understand by the letter that is written by your GP that you are referred to the clinic because your weight is slightly on the higher side, or your BMI is on the higher side. Or I understand that you've been referred to the clinic because you had a previous traumatic experience after your delivery, or because you had a third-degree tear in your previous delivery. Is that correct? She will say yes. Take it from there. Then tell her that, is it okay if I ask you a few questions? Then we will make a management plan together. Okay, and before you leave from here, I will give you some information leaflets, and I will also write a letter back to your GP or your midwife so that they are in the loop. So after this, then you start asking about her history of present pregnancy, and obviously focusing on the reason for which she is referred here, and try to follow the patient, address her concerns. For example, if she's here because she wants to have a pool birth, just see what are her concerns regarding hospital delivery and try to explore a little bit more in detail. Try to reassure the patient and try to tell her that you are there to help you. Do not ignore anything that is said by the patient. Try to listen to her more and try to talk to her less, at least in the beginning of the scenario, before discussing with her options, so that she has a feeling that she has been listened to. So after the history of the present pregnancy, reviewing her blood investigations, her ultrasound scans, and her concerns, then you can tell her that I will discuss with you all these things during the consultation one by one. Okay, but is it okay if I ask you a few more questions? Can you tell me about your previous pregnancy? Can you tell me, do you have any medical problems for which you are seeing your GP? Do you have any, did you ever have any operations on your tummy or down below? Do you take any drugs on regular basis? Do you smoke, use alcohol, or do you take recreational drugs? Any problems in your family? Very important part of the antenatal care, whether it's a maternal medicine, labor and delivery, or antenatal care, or any obstetric module, although it's also important in gynae and for any other patient as well, but especially in obstetrics, because women are at increased risk of DVT or thromboembolism. So VT risk assessment is very important. Okay, so try to ask specific questions with regard to VT risk assessment as well, to make sure that you are not missing on that. After you are done with the history of present pregnancy, her obstetric history, her general history, always ask about her social history and always see whether she has got enough support at home, whether she will be a single parent or she's got a support system around her who will be looking after her delivery, her baby and herself. And always ask about her mental health. That's also very important. You can ask Woolly's questions specifically, or otherwise you can ask about generally about her mood, about any history of anxiety or depression in the past, and how she's feeling at the moment. And after that, you can make a plan with her, addressing her specific concerns as well as her risk factors. For example, if a woman is referred because of her raised BMI, you tell her that women who have a raised BMI, people understand BMI here, so you don't need to say a height to weight ratio, but again, it's a personal choice. But I would say, do not complicate things by yourself and try to make them simple. If she understands BMI, just keep it simple. So if her BMI is on the higher side, you can tell her that because your BMI is, it's not impolite, because you are not saying obesity or anything like that. So you can tell her that if the BMI is on the higher side, if it's more than 30, then mothers are at risk of certain such problems in pregnancy, such as developing diabetes, high blood pressure. So what will you do for these things? So at the same time, also keep on telling her that, well, how will you help her? For example, if a woman is at risk of diabetes, what will you do? You will be offered a diabetic screening test between 24 and 28 weeks of pregnancy, so that we know that you are not developing diabetes in this pregnancy. Because of her risk of developing preeclampsia, she will be offered more regular or frequent follow-ups in the community to check her blood pressure and urine for proteins. Okay, and you can also tell her about some symptoms of preeclampsia. Then you can tell her about some intrapartum problems, for example, slow labor, more chances of having cesarean section, risk of PPH. Okay, and then at 36 weeks of pregnancy, offer her a review by the anesthetist. So you have got the basic knowledge. It's all about conveying your knowledge to the patient. And it's also important to let the patient lead again. And it's also very important to make sure that the patient understands everything that you are saying. So just keep on checking her knowledge in between throughout the station. Just keep on asking her throughout the station every 1 to 2 minutes, are you with me? Am I clear so far? Am I making sense? Do you understand everything up till now? Develop your own style. You can use any of these sentences. This is just an example. You know everything. For example, a woman who comes after a 3rd-degree perineal tear, you can tell her that she is at risk of having a perineal tear again at the time of delivery. So what you can do to help her, just tell her that. Okay, and you can tell her also the figures, that what is the risk of a first timer or a priming gravida having a tear, what is the risk of a woman who had a vaginal delivery previously having a tear, but because of her previous tear the risk is for her is nearly the same as a first timer mother. And how you can reduce the risk is by giving perineal support. You can also tell her about the chances of role of episiotomy, that it doesn't have any significant role. Okay, so these are just few examples. And then telling her about the options, that she can have a vaginal delivery if she's not symptomatic after her third degree tear, if she has recovered well. And also see what she wants. If she wants a cesarean section and she doesn't want to go ahead with that traumatic experience again, then, and if she's asymptomatic, then as per the guideline she can have a vaginal delivery. Then you can ask her to come back to the clinic for a consultant appointment. So this is how you can deal with the things when you have to negotiate with certain things. That is, tell her about all her options, appreciate that she knows everything and she has got a plan in her mind. So tell her that, yes, I totally appreciate that. For example, if she wants to have a cesarean section after her previous one cesarean section, you tell her about the pros and cons of having a cesarean section first, followed by the pros and cons of a VBAC. So do not tell her about the option that you think is correct for her first. Just listen to her and tell her that, yes, that's a very good option for you. Let me tell you the pros and cons of these options. The benefits are these and the risks are these. And the other option, that is trying for a vaginal birth. So the benefits are quick recovery and good bonding with your baby, going home early, things like that. And then what are the risks? Discuss the risks later on. So it's very important to let the patient lead the consultation, listen to them, and do risk assessment. Try to remember a few D's for the antenatal care: domestic violence, depression, DVT. So these are some important points when you are dealing with any woman who presents in the antenatal clinic generally, or when you are in an exam scenario and you are dealing with women in the antenatal clinic, and that is a question is basically related to the antenatal care module. Sometimes there may be an overlap of two modules as well, but you have to recognize the module that will make your life very easy. So identification of risk factors and remembering your 3Ds. If a woman comes with some fetal issues, then involvement of the fetal medicine unit could be very beneficial. And for all the women who have got any complications in pregnancy or who have got risk factors, then it will be an MDT care. It will not be only you or not be only the patient's midwife who is looking after her. It will be an MDT, which involves the consultant obstetrician, the obstetric team, the anesthetic team, or the anesthetists. Review at 36 weeks of pregnancy. And whenever you are discussing with the women the plan of management of pregnancy, try to discuss trimester wise. Try to go first trimester, second trimester, third trimester, labor and delivery, contraception and postnatal period. And if she's on any medication, then she needs to come off those medication at what time. For example, if she's taking the low molecular weight heparin, when can she stop that? If you do a VT risk assessment, it's important to tell her about that whenever she has got any signs or symptoms of labor before coming to the hospital, do not take your due dose of the blood thinning injection. And with regards to aspirin, she can keep on taking aspirin throughout pregnancy as per the NICE guidelines. So these are just few examples. I'm sure you've got much more knowledge than me and you know everything, but it is just how you will describe everything to the patient and how you can keep it very simple and very smooth as for the exam purposes. Thank you so much for listening, and please let me know if you want me to do anything else. Thanks. Bye.